Vitamin B12 deficiency is the medical condition of low blood levels of vitamin B12. A wide variety of signs and symptoms may occur, including a decreased ability to think and behavioral and emotional changes such as depression, irritability, and psychosis. Abnormal sensations, changes in reflexes, and poor muscle function can also occur, as may inflammation of the tongue, decreased taste, low red blood cells, reduced heart function, and decreased fertility. In young children, symptoms include poor growth, poor development, and difficulties with movement. Without early treatment, some of the changes may be permanent. Common causes include poor absorption from the stomach or intestines, decreased intake, and increased requirements. Decreased absorption may be due to pernicious anemia, surgical removal of the stomach, chronic inflammation of the pancreas, intestinal parasites, certain medications, and some genetic disorders. Decreased intake may occur in those who eat a vegan diet or are malnourished. Increased requirements occur in HIV/AIDS and in those with rapid red blood cell breakdown. Diagnosis is typically based on vitamin B12 blood levels below 120-180 picomole/L, 170-250 pg/ml in adults. Elevated methylmalonic acid levels, values greater than 0.4 micromole/L, may also indicate a deficiency. A type of low red blood cells known as megaloblastic anemia is often but not always present. Supplementation is recommended to prevent deficiency in vegetarians who are pregnant. Once identified, it is easily treated with supplementation by mouth or injection. There are no concerns from excess vitamin B12 among those who are otherwise healthy. Some cases may also be helped by treating the underlying cause. Other cases may require ongoing supplementation as the underlying cause is not curable. Vitamin B12 deficiency is common. It is estimated to occur in about 6% of those under the age of 60 and 20% of those over the age of 60. Rates may be as high as 80% in parts of Africa and Asia. Vitamin B12 deficiency can lead to anemia and neurologic dysfunction. A mild deficiency may not cause any discernible symptoms, but as the deficiency becomes more significant, symptoms of anemia may result, such as weakness, fatigue, lightheadedness, rapid heartbeat, rapid breathing, and pale color to the skin. It may also cause easy bruising or bleeding, including bleeding gums. GI side effects including sore tongue, stomach upset, weight loss, and diarrhea or constipation. If the deficiency is not corrected, nerve cell damage can result. If this happens, vitamin B12 deficiency may result in tingling or numbness to the fingers and toes, difficulty walking, mood changes, depression, memory loss, disorientation, and, in severe cases, dementia. The main syndrome of vitamin B12 deficiency is pernicious anemia. It is characterized by a triad of symptoms. 1. Anemia with bone marrow promegaloblastosis, megaloblastic anemia. This is due to the inhibition of DNA synthesis, specifically purines and thymidine. 2. Gastrointestinal symptoms, alteration in bowel motility, such as mild diarrhea or constipation, and loss of bladder or bowel control. These are thought to be due to defective DNA synthesis inhibiting replication in a site with a high turnover of cells. This may also be due to the autoimmune attack on the parietal cells of the stomach in pernicious anemia. There is an association with Gave syndrome, commonly called watermelon stomach, and pernicious anemia. 3. Neurological symptoms, sensory or motor deficiencies, absent reflexes, diminished vibration or soft touch sensation, subacute combined degeneration of spinal cord, seizures, or even symptoms of dementia and/or other psychiatric symptoms may be present. The presence of peripheral sensory motor symptoms or subacute combined degeneration of spinal cord strongly suggests the presence of a B12 deficiency instead of folate deficiency. Methylmalonic acid, if not properly handled by B12, remains in the myelin sheath, causing fragility. Dementia and depression have been associated with this deficiency as well, possibly from the underproduction of methionine because of the inability to convert homocysteine into this product. Methionine is a necessary cofactor in the production of several neurotransmitters. Each of those symptoms can occur either alone or along with others. The neurological complex, defined as myelosis funicularis, consists of the following symptoms: impaired perception of deep touch, pressure and vibration, loss of sense of touch, very annoying and persistent paresthesias. 1. Ataxia of dorsal cord type 2. Decrease or loss of deep muscle tendon reflexes. 3. Pathological reflexes, Babinski, Rossolimo and others, also severe paresis. 4. Vitamin B12 deficiency can cause severe and irreversible damage, especially to the brain and nervous system. These symptoms of neuronal damage may not reverse after correction of hematological abnormalities, and the chance of complete reversal decreases with the length of time the neurological symptoms have been present. Tinnitus may be associated with vitamin B12 deficiency. Vitamin B12 deficiency can also cause symptoms of mania and psychosis, fatigue, memory impairment, irritability, depression, ataxia, and personality changes. In infants, symptoms include irritability, failure to thrive, apathy, anorexia, and developmental regression. Vitamin B12 deficiency causes particular changes to the metabolism of two clinically relevant substances in humans. 1. Homocysteine to methionine, catalyzed by methionine synthase, leading to hyperhomocysteinemia, may lead to varicose veins. 2. Methylmalonic acid, methylmelanin-CoA to succinyl-CoA, of which methylmelanin-CoA is made from methylmalonic acid in a preceding reaction. B12 can be supplemented by pill or injection and appear to be equally effective in those with low levels due to absorption problems. When large doses are given by mouth, its absorption does not rely on the presence of intrinsic factor or an intact ileum. Generally 1 to 2 mg daily is required as a large dose. Even pernicious anemia can be treated entirely by the oral route. These supplements carry such large doses of the vitamin that 1% to 5% of high oral doses of free crystalline B12 is absorbed along the entire intestine by passive diffusion. In the developing world, the deficiency is very widespread, with significant levels of deficiency in Africa, India, and South and Central America. This is theorized to be due to low intakes of animal products, particularly among the poor. B12 deficiency is more common in the elderly. This is because B12 absorption decreases greatly in the presence of atrophic gastritis, which is common in the elderly. The 2000 Tufts University study found no correlation between eating meat and differences in B12 serum levels, likely due to a combination of fortified foods and B12 absorption disorders. Ruminants, such as cows and sheep, absorb B12 produced by bacteria in their guts. For gut bacteria of ruminants to produce B12, the animal must consume sufficient amounts of cobalt in order for B12 to be synthesized. In the early 20th century, during the development for farming of the North Island volcanic plateau of New Zealand, cattle suffered from what was termed bush sickness. It was discovered that the volcanic soils lacked the cobalt salts essential for the cattle food chain. The coast disease of sheep in the 90-mile desert of the southeast of South Australia in the 1930s was found to originate in nutritional deficiencies of the trace elements, cobalt and copper. The cobalt deficiency was overcome by the development of cobalt bullets, dense pellets of cobalt oxide mixed with clay given orally for lodging in the animal's rumen.